Ma'am, just sending the link, ma'am. Just sending the link, ma'am.
Did you start?
They're like,
Did you start? A very good evening, guys. So, getting up for the NEET. So, this is a very crucial time for all of you, and I think this ends your confusion whether exam will be postponed or whether exam will be on time. So, you all are now aware that you're going to have your exam on 21st of May, right? So, there's a notification which has come which has stated that we are going to have the exam on the 21st May. So just stick to your books, keep doing a lot of MCQs, keep revising whichever topics you feel weak or which you have felt weak. Be confident, don't trust yourself. Being calm is the most important. Don't be panicked. The panicky mode is something which spoils everything. So if you are able to keep yourself very stable in this time period, it will definitely help you all. Hi, very good evening. Welcome to the platform of Dr. Bhatia Medical Coaching Institute and eGurukul. Hi, Nasira. So I am looking forward that you all should do very, very, very well in the NEET. So I have kept around 3 sessions now, 3 practice sessions. That is today, tomorrow, and day after tomorrow at around 9 p.m. We are going to have a quick practice of MCQs, and you can let me know also what are the topics you want me to concentrate more so that I can put the MCQs from there. So we will start with today's session and we'll start with the MCQs. So starting with the first topic. Following is observed in which type of presentation? So see the picture. Let us take it as Zubair. Actually, it's a very tricky question. Whether it is on 21st. Let us take it as 21st. Let's see what happens. But because today again there was some hearing and some hearing to be there is a slightest chance, but maximum it might be on 21st. So let us consider it is on 21st. Mano agar postpone ho gaya, then it is a bonus for you all, right? To study more. But let us consider it as on 21st, okay? So we are going to do around 30 to 40 minutes, a short session, a quick recap of the things. So where we are going to quickly cover all the some topics in this session, okay? Right, so where do you see this type of presentation and what is this called as? A very important, a very, very important. So if you see this here, so from the placenta, when you're seeing a thin line, this is nothing but the, what do you call this sign as? So this looks like a T. So this is called as T sign. This is T sign, guys. This is T sign. And T sign is seen in monochorionic diamniotic twins. So you can see A and B, two presentations, and this at the junction it is like a T. So it is a T sign. Sure, Sharata, I'll try to show you. So there are two types, two things which you can see on the presentation. One is the T sign, which you see in monochorionic diamniotic presentation. The second one, which usually students get confused, is a lambda sign. Okay, now you might ask me, how do I differentiate between the T sign and lambda sign? You have to closely observe. They would have given here the P and all, right? Placenta. So even if they didn't give, also see the junction. So if you see the junction here from the placenta, the line is very thin and it is looking like a T. It is not like a lambda. I'll show you how does the lambda look like. So lambda will be thoda mota, guys. See, observe here. Is it not like a triangle? Agar from the placenta, if it looks like a triangle, then it is a lambda sign, and lambda or the twin peak sign. Lambda or twin peak sign is seen at, so go on quickly answering because this is a revision session. So lambda or twin peak sign is seen in dichorionic diamniotic. Dichorionic diamniotic. At how many weeks of gestation do you have this this lambda sign or T sign is visible at how many weeks of gestation? So lambda sign or twin peak sign to differentiate between type of presentation is observed around 11 to 13 weeks plus 6 days, that is around 14 weeks, 11 to 14 weeks. So if you see here, so in dichorionic diamniotic, you have two amniotic layers and two separate placentas. So when they're separating, you'll see a triangle that is called as lambda sign or twin peak sign But when you have monochorionic diamniotic, it is a single placenta and two amniotic sacs. So the junction will look like a T. The junction will look like a T. And if you observe the intertwin membrane also, for dichorionic diamniotic, intertwin membrane will be less than 2 mm, whereas for monochorionic it will be more than 2 mm, whereas for monochorionic monoamniotic it will be monochorionic diamniotic, it will be less than 2 mm, right? So as we have touched with the twins, I'll also tell you what are the other important points which you should be knowing in the twins. So what is the timing of delivery? What is the timing of delivery for monochorionic diamniotic twins? So solve past 5-year question papers, that is usually going to be fair enough, right? And don't be scared with the INEET paper. INEET was moderately tough, but if you were perfect with your notes, always you can solve it, right? NEET won't be so tough. NEET will be easy, and I want you to crack all the questions in NEET. That's the purpose of these sessions. So come on, quickly guys, we'll revise. So monochorionic diamniotic, what will be the timing of delivery for these patients? So monochorionic diamniotic, you will deliver them around 36 weeks. Dichorionic diamniotic will be around 37 to 38 weeks. Monochorionic monoamniotic, you will deliver them around 34 weeks by elective LSES after giving a course of steroids. Right? So that is regarding the timing of twins delivery. Next important which they can ask you in the twins is the mode of delivery. So when you have a 35 weeks gestation, monochorionic diamniotic presentation, patient in labor, first twin breech and second twin vertex, what will be the mode of delivery? What is the mode of delivery? So monochorionic diamniotic, 35 weeks gestation, patient has come to you in labor. First twin is breech, second twin is vertex. What is the mode of delivery? Option A, give tocolysis. Option B, LSES. Option C, refer. Option D, conduct vaginal delivery. Very good, Lakshit, Reddy and Sujit, excellent. As the first twin is breech, and patient has come to you in labor and she is beyond 34 weeks. See, before 34 weeks, you can wait. 60% of the twins will have preterm labor, so you can't help that because of the overstretch of the uterus. So as she is crossed beyond 34 weeks, lung maturity is there, you can conduct the delivery, you can allow them to deliver. But whenever the first twin is non-vertex, your mode of delivery will go for LSCS. A very important point. I hope you're all clear with this point. So whenever the first twin is non-vertex, your mode of delivery will go for LSCS. If in the same question, I would have given first twin cephalic, then what will be your answer, guys? If I would have given first twin cephalic, then what will be your answer? So if first twin is vertex, then obviously your answer will go for vaginal delivery. So the mode of delivery in twins will always depend on the first twin. So if first twin is vertex, you will go for vaginal delivery. If first twin is non-vertex, then you will go for cesarean section, irrespective of the second twin. अगर first twin vertex है, then vaginal delivery. अगर second twin कुछ भी हो, breech हो, कुछ भी हो, you're going to conduct vaginal delivery only. So if second twin is breech, you will do assisted vaginal delivery. If second twin is transverse lie, you will first try with external cephalic version. If that fails, you are going to do internal podalic version and you are going to do breech extraction. So the mode of delivery in the twins is dependent on the first twin, right? Next important point in the twins is one very specific complication which we have in twins is एक ट्विन मोटा, एक ट्विन पतला, एक ट्विन के पास ज्यादा पानी, दूसरा ट्विन के पास नो पानी, एक ट्विन लाल लाल, एक ट्विन सफेद सफेद. क्या है ये? What is this? Yes, all 3 sessions are absolutely free on the YouTube. So guys, you keep on messaging me what are the topics you want for tomorrow. So one I have seen here, contraception, hormonal contraception. Yes, I'll do it that. Excellent, Pancake. Very good. So that is nothing but the twin to twin transfusion syndrome, right? So this is another important point in the twins. So twin to twin transfusion syndrome is mainly seen in monochorionic diamniotic placentation. This is a very, very important point. So twin to twin transfusion syndrome is only seen in monochorionic diamniotic. Separate kamre hone chahiye. They have to have a separation. Only then ek can have more pani and another will have less pani, right? So it is a poly-oly sequence. They will be associated with poly-oly sequence, and usually they have a deep AV malformation, because of which one twin will be acting as a donor, another twin will be acting as a recipient. One twin acting as a donor, another acting as a recipient. So donor will be oligo, donor will have anemia, recipient will be poly, recipient will have polycythemia and polyhydramnios, and risk of cardiac failure and multiple thrombi. So what is it? You can stage it with Quintero staging. So staging is Quintero staging. Go through it once again. And treatment is fetoscopic laser ablation. And one last important is the timing of division of So monozygotic, depending on when does it divide, you have different types of placentation. So monozygotic depending on when does it divide has different types of placentation. If division takes place before 72 hours, then it will result in dichorionic diamniotic. If division takes place between 4 to 8 days, then you will have monochorionic diamniotic. If division takes place between 9 to 12 days, you will have monochorionic monoamniotic. If division takes place beyond 12 days, then you will have sati, full sath, Chipku twins, that is Siamese twins or conjoined twins. Can it be possible that there are twins born, mother is one, fathers are two? Is it possible there is a twin delivery where mother is one but fathers are two? Can this be possible, and what is the name of that? So that's a quick recap of twins. So in this way, I will be covering the most important points of each topic in these 3 days, guys. So hardly 45 to 1 hour you can spend with me, and we are going to revise the subject. Yes, Tej, okay, it is possible. What is the name of that? When mother is same, fathers are two, but it is a twin delivery. Excellent, very good, Nasira. Pancake, it is called as, no, it is called as superfecundation. It is not superfetation, it is superfecundation. Fecundation. Fake. Fetus नहीं, fake हो रही है ना. देखो, how to remember and how not to get confused is mother is being fake, है ना. So superfecundation. I know. This time it is better to remember everything in a, ऐसे ही याद रखना बेटर होगा. सो मदर फेक बन रही है, इसीलिए दो दो डिफरेंट डिफरेंट पार्टनर्स के दो दो डिफरेंट बच्चे. सो दैट इज कॉल्ड सुपरफिकेंडेशन, नॉट सुपरफिटेशन. ठीक है. सो सुपरफिकेंडेशन इज व्हेन देयर इज अ फर्टिलाइजेशन ऑफ टू ओवम्स in same cycle, in same menstrual cycle, but by two different intercourse, then you call it as superfecundation. Partner can be same or different, depends. Okay. So between दो बच्चे there is some gap of 1 to 2 days. Next. So I try to keep a little tricky and difficult question. So one easy, one difficult. That's how we are going to practice. In the developmental progression from the childhood through puberty to menopause, all of the following statements regarding the levels of FSH and LH are true, except, yes, Nazira, you're correct. That was last year's question. FSH is suppressed from birth to 20 months of age. LH is increased. Guys, there is no, I'll tell you one more thing. This is something probably little new to you, but always remember, like in your INEET, I have taught you all the cerclages which are done in pregnancy. So you all know that we do worms for rescue cerclage, we do Benson and Durfee, which is an abdominal cerclage. I make a joke also, it is Benson and Burfee, nahi hai Durfee karke, right? So Benson and Durfee is also, and laparoscopy can be performed. So you never heard of lash, so you could have ruled out and gone to the answer of lash. Sometimes you should use your power of ruling out the things. So you might be knowing most of the options, and then which you don't know probably can be the answer. So like that. So use that ruling out here and try to answer this question. Okay? But attempt it. LH is increased during the neonatal year, birth to 20 months. LH and FSH levels are reduced during childhood before puberty. At the onset of puberty, pulsatile gonadotrophin releasing hormone drives the pituitary LH and FSH levels. LH and FSH levels rise sharply after the menopause. Okay, let us start from option E. Option E, you all absolutely know it. Ki menopause mein FSH and LH levels will be very high because there is no negative feedback. Does anybody can tell me how much will be the levels of FSH and LH in the menopause to call it as a menopause? They are not asking which is true. They are asking which is not true. All are true except. Don't forget to read except, guys. Next, at the onset of puberty, pulsatile gonadotrophin releasing hormone drives the pituitary FSH and LH levels. This also we know that only when we have pulsatile GnRH, we'll have FSH and LH levels. And we also know D and E are correct. LH and FSH levels are reduced during childhood before puberty. We all know this also. Puberty mein there is no FSH, LH, there is no estrogen, right? Before puberty. LH is increased during neonatal year, birth to 20 months. This and option A we are not knowing. So either can be A or B. Now let me answer you. So soon after the birth, up to 20 months, that is in the infancy, you have increased FSH and increased LH. So soon after the birth, up to 20 months, you have increased LH and increased FSH. Very good. Some of you have answered correct that FSH level more than 40 indicates that we are dealing with menopause. From 20 months to before puberty, LH and FSH levels are constantly low. Then when we have the pulsatile GnRH, we will have again FSH and LH being produced. So pulsatile GnRH stimulates the FSH and LH release. So when you observe, LH will be high amplitude. LH will be released in a pulsatile manner in a high amplitude. Whereas FSH is low amplitude. FSH के pulses जो है ना वो low amplitude है. LH high amplitude है. Okay. And post menopause, LH and FSH both will become high because of the no negative feedback. So this is in total how does the FSH and LH keeps on changing in the female. Okay. Now who can tell me what is the main function of FSH? What is the main function of LH? Right, I am taking into consideration all the topics which you are keeping here. Definitely I'll be doing those. So FSH helps in the growth of the follicle. So recruitment of the follicle, growth of the follicle, all that is by FSH. Whereas LH surge helps in ovulation and resumption of ovulation. Resumption of meiosis 1. And it helps in ovulation. Ovulation is not just because of LH surge, ovulation is because of both LH surge plus FSH surge. Excellent, very, very good, very, very good. So if I go back, so FSH is suppressed from birth to 20 months is false. FSH and LH both are raised in the neonatal period. So B is also a correct statement. So A is the wrong statement, right? Now let us go to the next question. Never be scared of a lengthy question. Have patience. आराम से पढ़ो. You can definitely answer. ठीक है? 42-year-old. First thing striking my brain, 42-year-old pregnant means elderly. है ना? Presents to the labor ward at 34 weeks of gestation in preterm labor. She progresses very quickly and proceeds to have an emergency cesarean section for fetal distress. She was discharged home after 1 week as her baby was admitted to special care baby unit. 2 weeks later, she attends the general practitioner center seeking contraception. She wants to continue to breastfeed her baby. So what will be the contraception of choice for this patient? What will be the? So try to answer this question, guys. Yes, Sridhar. So there is rise in FSH and LH post after menopause because there is no negative feedback on FSH and LH. Normally, estrogen downregulates the FSH and high levels of progesterone downregulates the LH. But in menopause, there is no estrogen and progesterone. So there is nobody to control the LH and FSH. जैसे बीवी चली गई हो. So this FSH and LH will be full and rise, full on. Very good, excellent. So here the patient is coming to you almost after 3 weeks after her delivery. So 1 week so she stayed in the hospital itself. Uske baad 2 weeks ke baad she has come. So she has come to you 3 weeks after her delivery. So you cannot keep, condom is not at all a contraceptive of choice because condom has very high failure rate, right? Can you give OCPs in lactational women? No, because oral contraceptive milks decreases the milk amount. Right, so don't give OCP. I can't insert IUCD also here. So that is why lactational pill or the progesterone only pill will be the choice. Now a quick go through of very important points regarding the lactational contraception. So in lactational contraception, within 48 hours, if a patient comes to you within 48 hours and if she wants a permanent sterilization, within 48 hours your contraceptive of choice will be IUCD. So you can put copper T 380A which will be effective for 10 years, or you can put copper T 375. Right? So you can, within 48 hours of delivery, you can put IUCD. So IUCD can be put postpartum, that is within 48 hours, or it can be put in immediately in the third stage after the placenta has come out. That is called as post placental. So you can either put post placental or you can put postpartum, right? Next, so IUCD is contraindicated from 48 hours to absolute, matlab actually 4 weeks. 48 hours to 4 weeks is absolute contraindication. There's high risk of perforation because uterus is involuting. 4 to 6 weeks post delivery, it is relative contraindication. If she comes to you beyond 6 weeks, then IUCD can be placed, right? Next, coming to the POPs. So POP is a lactational pin which you can start, right? Coming to OCPs, oral contraceptive pills are absolutely contraindicated from birth up to 6 weeks. From birth up to 6 weeks. And 6 weeks to 6 months, they are relatively contraindicated. 6 weeks to 6 months post delivery, they are relatively contraindicated. So if in the same question, if patient is coming to you after 6 weeks, then what will be your contraceptive of choice? Suhail, obstetrics and gynecology is a very, very easy subject. It's lot fun actually. You can feel free. You can feel free to message me on my, you can DM me either in the Telegram or on the Instagram, anywhere. Suhail, I'll try to help you out what you're missing or what you're feeling it difficult. Okay. So obstetrics and gynecology should be made as an easy subject for everyone. Matlab, easy hai. Right? So you can, this is my Instagram handle. You can follow me on this handle, guys, or any of the Bhatia groups. You can message me also, tag me. Right, post 6 weeks it is mainly the IUCD. Post 6 weeks it is mainly the IUCD, right? Okay, next questions. A female at 37 weeks of gestation has mild labor pains for 10 hours. Cervix is persistently 1 centimeter dilated but not effaced. What will be the next appropriate management? So basically it is easy, but questions will be little tricky, है ना? So I have Arun answering it. What about the others? So here she is 37 weeks, mild labor pains for 10 hours. So what is the diagnosis for this? From 10 hours she is 1 centimeter itself. So this is nothing but the false labor pains. This is nothing but false labor pains. When she is not progressing at all but only contractions are there, so you call it as false labor pains. So what will be the management in the false labor pains? So the management in the false labor pains is sedation and wait. Don't touch the lady in the latent phase. Don't touch the lady in the latent phase. Okay? Now quick recap of labor and number of hours I will quickly tell in a one go, so that you have to remember this one page. That's all. So first and foremost, So we have 4 stages. First stage is from onset of true labor pains to full dilatation. So you have latent phase and active phase. Latent phase or active phase. True labor pains are associated with cervical changes. In the previous question, there was no proper contraction and the cervix was remaining 1 centimeter without any effacement for past 10 hours. So she should have been progressed little at least, right? She didn't progress. So you can consider it as false labor pains. Or if you consider it her to be in latent phase also, no problem. The answer will remain same. Don't touch her anything when she is in latent phase. So latent phase is 0 to 5 centimeters according to the new Williams, and active phase is 6 to 10 centimeters. Right? Latent phase में primary multi. Primary on an average takes 10 to 12 hours to complete the latent phase. Multi takes 6 to 8 hours. When do you call prolonged latent phase? When latent phase is beyond or equal to 20 hours in primary, more than or equal to 14 hours in multi, you call it as prolonged latent phase. Jo bhi ho, the treatment is same, just give her sedation and rest. So no worries when she is in latent phase. So agar koi bhi question labor ke bare mein if you are seeing, first ask yourself, she belongs to which stage? If she is in a latent phase, don't touch her unless the baby is having fetal distress. Okay. Next, coming to the active phase. Active phase. Active phase is 6 to 10. फिर से primary multi. So on the rate of descent and rate of dilatation, these are the two things which you have to see. Rate of descent and rate of dilatation. Very good, Venus. Excellent. After a long time, but yes, excellent answering. So rate of dilatation is 1.2 centimeter per hour, 1.5 centimeter per hour. Rate of descent 2 centimeter per hour, 1 centimeter per hour and 2 centimeter per hour. Manu, you are feeling, Abba, I can't remember so much. What is this 1.2, 1.5? Remember, for your solving MCQs, rate of dilatation or rate of descent, whether it is primary or multi, it should happen minimum 1 centimeter per hour. So according to WHO, it should happen minimum 1 centimeter per hour. So 6 to 10 centimeters, she should finish in the 1 centimeter per hour. If she is taking more time, then you call it as prolonged active phase. If she is taking more time, then it is called prolonged active phase. So what are you going to do when you have a prolonged active phase? Check where is the problem. Is it the problem with passage? Agar contracted pelvis या CPD है, LSCS. Check whether the problem is in the passenger, that is in the bacha. Then if whatever is bacha, transverse lie, LSCS, OP, wait and watch. So you have to check whether it is a passenger. If it is the power problem, if it is the contraction ka problem, so you have to augment the labor. Tell me, how can we augment the labor? How can we augment the labor? So augmentation can be done by artificial rupture of membrane or followed by oxytocin. Right? Next you have, agar dilatation is not progressing beyond 4 hours, then you call it as active phase arrest. Cervix will be more than 6 centimeters dilated, membranes absent, and when there is no dilatation for 4 hours with adequate contraction or no dilatation for 6 hours after giving oxytocin, then you call it as active phase arrest. You have to go for LSCS. You have to go for LSCS. Okay? That is about the first stage. A quick recap of second stage. Second stage is from full dilatation to bacha coming out to delivery. Right? So again you have primary and multi. Then again you have normal on an average how much time it takes. Prolonged second stage and second stage arrest and second stage arrest. So how do I remember this graph? So I remember it by 1, 2, 3. 1, 2, 3. Remember like that. So 1 hour, 2 hours, 3 hours. So when that something related to this question comes, this graph should print in your brain. ये graph आपके दिमाग में बल्ब जैसा आता रहना चाहिए, है ना? And multi में 30 minutes. Prolonged second stage is 1 hour. Second stage arrest is 2 hours. So what will be the mode of delivery? What will be the mode of delivery? Average में Ridgens manure से आप बच्चे को बाहर निकालते हो. When you have prolonged second stage, you cannot wait anymore. You have to deliver the baby. If the बच्चा का head is down below +2 station, you can do instrumental delivery, that is vacuum or forceps. Okay. If the बच्चे का सिर is high up, above +2, then you have to go for vaginal delivery. And second stage arrest is nothing but obstructed labor. So either there is a problem in the bacha or there is a problem in the passenger or passage. So what will be the mode of delivery when you have a second stage arrest? Your mode of delivery after a second stage arrest is LSCS. If bacha is dead with second stage arrest, then what will be your mode of delivery? You have a dead baby with second stage arrest. What will be the mode of delivery, guys? So whatever might be, whether baby is alive or baby is dead, if it is a second stage arrest, it is LSCS. There is no role for destructive operations in the modern era. Okay, right. So that finishes the first stage and second stage. Quick revision. Quick revision. Next, I have put one more wonderful question. Yes, this question. So something similar to this has come previously, and I don't know, every year I'm seeing one cord prolapse question, something related. So I have kept this question. Let us answer. A 28-year-old woman presents in the spontaneous labor at 41 weeks of gestation with cephalic presentation in her third pregnancy, having had 2 previous normal births. At the onset of second stage, she ruptures her membranes and the fetal heart rate decelerates. Vaginal examination confirms umbilical cord prolapse with fetal head in direct occipito anterior position at +2 station. What is the optimal management? Yes, Saurabh, above +2 we have to go for LSCS. Head high up, you have to go for LSCS. Head niche, you can do instrumental delivery. So here, baby is way too down. Baby is down and there's a sudden prolapse, cord prolapse. Tell me which will take more. Basically, you want to deliver this baby at the earliest, right or not? है ना? See how your answers and how your question can change depending on the scenario. That is what I'm trying to make you understand. आपका approach important है. Cord prolapse you would have read. Cord prolapse means cesarean section. No, everywhere same answer won't be there. It changes depending on the situation, and how to approach for that situation is what you have to learn, guys. Now, in this question, cord prolapse mein there is a risk of fetal distress. One important point in cord prolapse you have to remember is never touch the cord. Don't do handling of the cord, right? If she is somewhere outside, if you want to refer her, then you can do bladder filling and you can put her in the replace. No replacement, no touching the umbilical cord. You can do bladder filling but no touching the umbilical cord. Okay, and you can refer her, right, with reverse Trendelenburg position and bladder filling, all that. Right, now this patient jiska head is two-way down, low down, which is quicker? Would you like to conduct doing instrumental delivery will be quick in this patient, or shifting her to OT, giving her anesthesia and then delivering her? कौन सा जल्दी होगा, guys? She's already in hospital, so I'm not definitely going to anticipate normal delivery here. There's a fetal umbilical cord prolapse which requires an urgent delivery. Bladder filling can be done, but replacement of never touch the cord, right? Now, between these two options, which one do you prefer? Yes, I shift her, I give anesthesia. Better than that is immediate operative vaginal delivery with ventouse or extraction, because it's going to be quick and I can deliver the baby quick as the head is down. Okay. Now same question. If I would have written -2, if head is -2, then what will be your answer? Very good, doomed. Excellent. नाम चेंज करो, डूम्ड नहीं लिखना, कुछ पॉजिटिव नाम रखो. So always be positive, guys. What we ask, that's what we get, right? So if I would have written in the question -2, then my best answer will be going for cesarean section under general anesthesia, right? Yes, excellent. So then C-section. So did you understand how to approach the question, how your answer might change? That is what I want to teach you through these sessions. Okay, right. So that's for today, guys. That's for today. Now, so tomorrow, what all I have got. So today, if you observe, we have learnt about labor and we have finished about twins, right? This is what we have learnt in today's session, and a little about the reproductive physiology. So tomorrow, I have seen you people want me to teach about some points about GTN. Then contraception, I think today we have discussed, but yes, tomorrow also we will discuss some questions on instruments. Yes, biophysical profile, you got scared, I guess. Yes, we will do biophysical profile. NST. Hannah, these are the topics you want. Any other? Malpresentation. Okay, we will do MCQs from these topics. Don't worry, no worries at all. No worries at all. We'll do one question here and end. That is partograph. Right, tomorrow then I'll keep one question on partograph, one question on NST, and yes, I'm also feeling somehow partograph can come for us. So one question on partograph, one question on NST, biophysical profile, instruments, malpresentation and GTN. Okay? So tomorrow we'll deal with these topics. Come back at 9 p.m. Be positive, keep studying. You are going to rock in this exam. You are going to get your dream branch, dream college, 100%. Just believe it. Just keep on giving this thought. You know, thoughts can also work wonder. आप hard work करना alone नहीं. आपके thoughts also will do wonders. So keep that positive thought. Ki, yes, I'm going to get my dream rank. I'm going to get my dream branch. Daily, just go on telling these, and yes, somehow you will get it. And probably whatever you read, only those questions will come. तो कुछ भी हो सकता है ना? So see you all tomorrow at 9 p.m. and let us discuss some more questions. Hopefully whatever we discuss should come in the exam so that you all rock it, right? Thank you guys. Good night. Sweet dreams. Yes, I'm gonna, okay, no problem. Prolapse also. ठीक है? Right. Thank you guys. Bye. See you tomorrow. So any queries before I end that session?